the plenary session. We are pleased to have Dr. Ken Beaufort from South Africa, our guest from the International Surgical Society, who are joining us this year for our conference. He's going to give us a talk on the treatment of bleeding is to stop bleeding, management of hemostasis in surgery. We're pleased to hear your talk, Professor Ken.
Professor, thank you very much. Thank you all for your invitation on behalf of Andrew Hill, myself, and our other guests. It's a real privilege to be here, and it's a privilege to be associated with the Egyptian Society of Surgery through ISS, and we're looking forward to a very long and fruitful association. I'm a trauma surgeon. I come from Johannesburg. Whatever you have read, Johannesburg is peaceful. Our murder capital is Cape Town. Don't go to Cape Town. But I would have to say, driving in yesterday, I have discovered some things about Alexandria and Egypt. The first is that no one in this country wears seatbelts. The second is no one in this country wears crash helmets. And as far as I can see, many vehicles in Egypt regard red lights and white lines on the road for personal guidance rather than for any law thing. So you have a lot of car crashes, and I think you probably have a lot of people who bleed. So we've titled this lecture, and it's not just for trauma, the treatment of bleeding is to stop the bleeding. And it's going to happen. It's not if, it's when. And if you do not plan when your patient bleeds, what are you going to do next? This plane didn't expect the giraffe to walk on the runway. The runway did not expect the plane to land. 2 victims, no winners. So the treatment of bleeding is to control the bleeding. And we don't want to wait until the patient is bled to death. You need to be thinking about this in advance. So what I want to talk about is how do we limit the blood loss? When do we stop it? On the top right of your picture, that's a horrible injury, but it's not bleeding that much. On the bottom of your picture, there's an awful lot of bleeding there that we need to be doing something about. You can stop it either locally, regionally, systemically. And the trouble is, every time we get a new tool, we think this is the answer. I will mention, and I know Andrew's going to mention, Reboa. Talk a little bit more about it. A great technique until somebody tells me what it's actually used for. So we've got to match the management. In terms of bleeding, in fact, many of you will know that there is clotting that happens in the blood. Many of you will remember back to your medical school days that there are 13 clotting factors. And that is obsolete. There are actually 14 clotting factors, and factor 14 has stopped more bleeding than the other 13 put together, and it is not a chemical, it is the surgeon's finger. The treatment of bleeding is to stop the bleeding, and if you can put your finger on it, I promise you it may stop it bleeding far more effectively than chemicals. So mechanical, factor 14, that's why we're here, that's why we're in this room, that's one of the reasons why we are surgeons. You can put Foley catheters into a stab wound and blow it up. There's lots of different chemicals you can put in, and we'll just talk about them briefly. You've got regional control. They talk about 3 sorts of bleeding. Visible bleeding, you can press on it, surgeon's finger, or a swab. Palpable bleeding, you actually have to put your finger in and get close control. And audible bleeding is the worst sort. When you can hear it going whoosh, that's a very bad idea. And you have to get regional source control. So there's lots of ways of doing it. But the commonest factor of all is the surgeon. The treatment of bleeding for us as surgeons is 1, try not to have it happen, and 2, if it happens, stop the bleeding. We use a number of local preparations. Those of you who are in the military will be familiar with them. Chitosan is taken from prawns. You have a lot of shellfish in Alexandria. and it stops bleeding, and it also sticks to the bleeding. The chemicals in it, when it's put on as a bandage, will stop bleeding. The military tend to use quick clot, which is very exothermic. If you put this on a wound, the temperature at the site reaches 80 degrees Celsius. You get what is a burn. It does stop bleeding. Nowadays it comes like tea bags. You put the tea bags in the wound or on the wound, bandage it on, and it will stop bleeding, but there is tissue damage that goes with it. And then we all know about angioembolization. On the left of your picture is a big bleeding in the liver, but there's not very much there. On the right of your picture, in the middle of the liver, you can see that large amount of blood, and that will have to be embolized. Tourniquets, unfortunately, started off as military, but became civilian as well. The difficulty is that they can be put on for too long. So if you ever get a patient who comes in with a tourniquet on, please be very aware that that patient may have had that tourniquet for some time. And when you look at the tourniquet, every single tourniquet will have a little tab on it, and that tab allows the time in which it was applied to be written, because we in civilian practice are seeing more limbs lost from a tourniquet that's been on for 8 hours than bleeding saved. So there are advantages. That gentleman on the bottom right of your picture, that could have been pressed on locally. He lost his leg as a direct result of that tourniquet. We all know angio intervention, angioembolization, and it really works very well as long as you have the facilities available. Waiting 4 hours while the patient is bleeding is frankly not a good idea. Reboa, new thing, resuscitative endovascular occlusion of the aorta. It's percutaneous through the femoral artery, pushed up into the aorta, and it is blown up. Great. It has a downside. Firstly, anything above it will bleed more, and secondly, anything below it will develop ischemic necrosis. So I feel with Reboa that there is the indication coming in, and there are the problems associated with it, and you don't know which one is going to be your problem. It's a technique. It has yet to find an indication. If you cannot stop the bleeding, if the person continues to bleed, they will develop a coagulopathy. Now, unfortunately, as surgeons, we regard coagulopathy as a failure, which it probably should be. If you haven't stopped the bleeding, you will get a coagulopathy. If you get a coagulopathy, it's because you have not stopped the bleeding, and they are going to bleed more. It is, after major trauma, the commonest cause of mortality, because you lose blood, but very few people have blood to replace. There is a think tank in Norway run by Americans and Norwegians called THOR, Traumatic Hemostasis and Operative Resuscitation. And their motto is, the treatment of bleeding is fresh blood. The use of salt water should be restricted for cooking pasta. And probably a liter of crystalloid is the maximum permitted in 2019 for a trauma patient. On the other hand, we know that there are a lot of problems from transfusion. The more units of transfused blood, the more ARDS, the more multiple organ failure. That's linear. 2 units, so much. 4 units, twice as much. But there is a major association between blood use and immune suppression. I don't have to tell the colon surgeons in the audience that those patients who get a blood transfusion have a higher recurrence rate of their cancer than those who do not get a blood transfusion. It's also, there are 23 pathogens that blood carries. There's a whole lot of diseases. There's ABO incompatibility, there's viruses, there's all sorts of things. And this is again an American term. Blood transfusion, the Americans sometimes are a bit like this. Transfusion is like marriage. Never enter into it lightly, unadvisedly, and never use it more often than is absolutely necessary. Anybody think that the American FDA would grant a license for this? So we've got to minimize the use. Treatment of bleeding is to stop the bleeding. Biggest problem, even in Egypt, you have 28 degrees outside. It's fabulous. If I go into your emergency department or operating room, I'm prepared to bet the temperature is going to be 21 degrees, give or take. I'm prepared to bet that all of us put on protective equipment, and then all of us take the clothes off the patient and the patient freezes. The average temperature loss in a trauma patient in South Africa and in the United States, and I suggest Egypt, is 2 degrees per hour. 90 minutes in the emergency department or operating room combined, you have a temperature down to 34 with a 25% bleeding mortality. The only policy I have in my department is any patient who takes longer than 90 minutes between admission and ICU, we independently peer review. You heard Andrew saying perfection is the enemy of good. Did we spend too much time in CT scan, emergency department, or the operating room and kill our patient with hypothermia? There are a number of additional things you could do. I'll talk a little bit more about tranexamic acid. Recombinant factor 7A, occasionally useful, around 10,000 US dollars a dose, therefore kept until it's too late. Tranexamic acid, very big trial. Is tranexamic acid used at all in Egypt routinely? The gynecologists use it. Very cheap, big trial, 20,000 patients, half with and half without. Fewer patients died, but they only received 3 units of blood, and then they ran out of blood in all aspects of the trial. So TXA is not for use in major urban centers like Cairo and Alexandria. It may be used in remote or rural areas, not otherwise. And a minute or two on what is now probably the gold standard for care of the trauma patient who is bleeding, and frankly, for the long operative patient. Those of you who do pancreatic surgery, those of you who do liver transplantation and liver resection, you will possibly spend more than 90 minutes. You will end up with a patient who is coagulopathic despite best efforts. Your mother-in-law, when she bakes bread and you ask her, how much what do you put in? She says, I don't know. I put a little of this and a little of that and I taste it. And you say, mother-in-law, you have the best bread in the world. You have to say that. Now, a TEG is pretty much like that. What we do, we know that for bleeding, the most important item that makes you clot is called tissue factor. So we take a small cup, little 1 cc cup, and we make a plunger in it and we put tissue factor in, the blood goes into that, and we look at how soon the blood takes to clot. And initially, for about 8 minutes, nothing happens, and that's the R time. And then the blood, clotting factors make fibrinogen go to fibrin, and they make platelets go sticky, and that's the gray area of that. It takes about 2 minutes. And then you get a clot forming, and eventually it stops, and some clots will break down. That is rather like your mother-in-law testing a clot. Not tasting, testing. So we can look at this, and it is a very easy, readily available point-of-care test. It takes between 12 and 20 minutes, and we know exactly which clotting factor is missing. If the R time is missing, it means the patient has not enough clotting factors. These ones need fresh frozen plasma, clotting factors, octoplex. But if it still doesn't work, then they may need factor 7A. If the alpha angle is decreased and the K time is decreased, that means your fibrinogen is not working. So even if you have enough clotting factors, you need fibrinogen. DDAVP, clopidogrel and aspirin stop platelets clotting. DDAVP reverses that. So you can make your platelets more effective. If the maximum amplitude goes down, it means you don't have enough platelets. So we have a very easy laboratory test, which is now the gold standard to say, what should we replace? Best practice says a massive transfusion protocol. Emergency blood has got to be readily available. Ideally, we don't use salt water, we use whole blood. If you do not have whole blood, fresh frozen plasma must be available, platelets must be available, packed red cells must be available. Cross-matched is best of all. And I think most people now would try and use a unit of cells plus a unit of fresh frozen plasma, and for every 4 to 6 of those, a unit of combined platelets. And that's what happens. But it's expensive. With the best will in the world, you're probably looking at 10 to 20,000 Egyptian pounds for a massive transfusion protocol before you start, at least. And that becomes expensive. Treatment of bleeding is not to treat bleeding, it is to prevent it. We don't measure all of these things nowadays. We don't do INR, we don't measure fibrinogens and platelets and so on. We do a thromboelastogram. That is the reality, because we know what we have to give in order to stop bleeding. It's called goal-directed hemostasis. So the two biggest changes is we have improved our ability to stop bleeding by better adjuncts, the surgeon's finger, regional angioembolization, maybe Reboa, and better management of coagulopathy. And we keep at that until we reach the endpoints where there is no active bleeding. Patients 15 years ago in this situation bled an average of 20 units of blood. The same patients in 2019 with damage control resuscitation, no salt water, damage control surgery, appreciation of where the missing blood clotting factors are, average 8 units. So we've come down from 20 to 8. The mortality has dropped from 30% to 8%. We are doing something right. Blood transfusion in some respects is an admission of failure. Blood transfusion says I could not stop the bleeding soon enough. With proper hemostasis that is goal-directed and understanding direct management, regional management, and general management, we can stop bleeding in most patients, and you're going to save a lot of lives, whether you're in trauma or whether you're in breast or whether you're in liver or anything else. The treatment of bleeding is to stop it happening, and if it happens, to stop it continuing. Thank you very much indeed for your time.
This is a plenary lecture. We are not expecting a lot of questions, but we'll give a chance for 1 or 2 questions. Dr. Medhat Khafaga, Professor Khafaga from the NCI.
Well, in Egypt I tried, and I'm doing it, auto donation from the patient before operation to avoid blood transfusion. I'm practicing it since 1983. When I saw a doctor, I don't remember his name, in Johns Hopkins doing radical prostatectomy, he said to me that this gentleman is 82 years old and we took from him 3 units of blood within 2 weeks. And after operation, when you do the hematocrit, you find it is more than before blood donation. Really, I tried this for many, I am doing it now for all of my patients who need blood. But in the National Cancer Institute where I'm working, I failed to convince the surgeons for auto donation. What do you think the problem with their minds?
Firstly, surgeons are difficult to convince. We were taking stomachs out for an infection called Helicobacter for a very long time. What you're talking is blood conservation. The optimum hemoglobin for most patients, for most things, is around 9 to 10. So you've got some in reserve, and doing what you're doing, although there are less in the way of clotting factors active and less oxygen carrying, is enormously useful. In trauma, of course, nobody phones me and says, I'm going to have a car crash in 1 week's time. Will you take some blood so when I have my car crash? So blood conservation, I think, like Andrew was talking, it's very much part of ERAS, of preparing your patient as best you can for the surgery you need. My compliments.
Do we have any more comments? Yes, Dr. Adel Fuad Ramzi, Professor Adel Fuad.
What's your opinion about the use of red cell saver?
The use of?
Red cell saver. The
We
use and the
routinely
value.
use red cell as part of our, there are two things. One is the blood transfusion. The other is conservation, and there are many techniques, one of which is to bleed your patients beforehand. The other is to use what you can. I don't know if you have Jehovah's Witnesses in Egypt. Many of them will not take blood transfusion, but as long as the blood is not deemed as having left the body but stays in the tubes of cell saving, that is often acceptable. So we do routine cell saving, blood washing and return of red cells. We would do it as a routine. It's a very useful blood conservation adjunct. Yep, absolutely.
Any more comments from the floor? Okay, thank you very much, Professor Ken Beaufort. We'll close this session now.